Good evening, everybody. My name is Rebecca Nebard, and I'm the marketing manager for Bausch & Lomb Specialty Vision Products in Boston Materials. And I want to thank you all for attending tonight's presentation, Materials Considerations in Scleral Lens Designs with Dr. Resnick. Right now, I'd like to take this time to introduce Ed Luce, our Senior Boston Regional Sales Manager that covers the Americas. Ed, thanks for joining us tonight.
Thank you, Rebecca. And thank you everyone out there for joining us tonight. We're very excited. This is the second in a series of webinars that we're producing, and we're more than excited to have Dr. Susan Resnick with us tonight. Dr. Resnick is going to take us through various cases in her practice where material choice has made a positive difference, and it's going to be a great night. Just a little bit about Dr. Resnick. She's president and managing partner in the New York and Long Island practice, Drs. Farkas, Castillo, Resnick Associates. She's been there for over 25 years. She's a very sought after author, lecturer, as well as a consultant to the ophthalmic industry. Dr. Resnick is also a diplomat of the Cornea and Contact Lens section of the American Academy of Optometry and the Board of Optometry. So comes with a huge list of qualifications. She's a great presenter. She's got some excellent material for you tonight, and we're very excited to have her. So without further ado, Dr. Resnick, it's all yours.
Great, thanks, Ed. Thanks everybody for joining. I'm gonna click off here and let's get started. So as Rebecca said, tonight's talk is on material considerations in scleral lens design. And so most of us have probably attended a lot of webinars and in-office or national meetings where we did wet labs. And what were we mostly focused on? We were focused on how the lens is fitting, what do we do to make changes to get a better fit, what diameter do we use? We were looking at the anatomic properties of the lens and the refractive properties of the lens. But think about the last time you actually thought about the material you were ordering your scleral lens in. And I will submit to you that that is equally, if not more important, in so many of the patients that we see. And so we wanted tonight to discuss how scleral lens fabrication comes into play with our choice of materials, and how do the materials actually further support the clinical outcomes that we're looking for. So if we go ahead, let's look at Contact Lens Spectra's annual GP prescribing survey. Let's look at what all of us are doing now in the gas permeable lens space. So if we look back to 2018, of the gas permeable space, 23% were in sclerals, and in a short 2 years, we've increased that 5%. So it shows you that most of us are embracing sclerals at a pretty rapid pace. And the reasons are numerous. We're all better educated. The laboratories have given us incredible support with their consulting, as well as their development of the fitting platforms and the product portfolios. And laboratory consultants continue to be an asset in helping us help our patients. But really, what's increasingly happening is that we're reaching for scleral lenses, not just as a last resort. We're embracing these scleral lenses now more and more for normal contact lens or normal corneal patients and normal refractive error patients. So we're going to actually be talking about that in a little bit as well. So let's just delve into review the clinical benefits of scleral lenses. Why do our patients tell us that these are life-altering? Well, the first reason is that they are comfortable. We know that they don't rest on the cornea, they rest on the sclera. So there's nothing that's interrupting with the epithelium or the nerve supply to the cornea. They give excellent on-eye centration and stability. We all know that with smaller diameter lenses, they move with the blink, and those lenses are subject to the forces of the lids as well as the shape of the cornea. We know that we can get virtually any vision correction. And again, this is where, and we're going to talk about it again, where does refractive error come in? And it's not only for our diseased corneas. These are not just for medical necessity. We're looking at, prescriptions that may not be as happily approached with either soft lenses, hybrids, or smaller gas permeable lenses. And finally, I think where most of us often reach for it secondary to the shape problems with corneas, we know that it can hold a great tear reservoir. So it's a great tool for ocular surface protection. So let's take a look at just a few little slides. Now, Dr. Johns was kind enough to loan us these slides, and these pictures actually show what the problems can be with smaller intra or interpalpebral small rigid gas permeable lens problems that we'll have. And we know that scleral lenses, they have the rigid lens optics, so we get the great vision, but on irregular corneas, we can avoid some of the issues we're seeing here. So on the top right, we have a small lens on an ectatic cornea, and we know that these lenses gravitate towards the inferior aspect of the cornea, which is where the cornea is mostly steeper. If we look in the middle, we can see a larger lens fitting flat on a cornea, and this was not a scleral, this was an intralimbal, but look at what you see in the middle there. You're seeing epithelial disruption. So, and this is a patient who they tried to refit her into steeper and steeper lenses, but we all have patients like that where you try to get that lift off the cornea and the patient is unhappy with the vision or unhappy with the comfort, but we worry about some other sequelae, which we'll talk about. On the left here, unfortunately, this was an aphakic patient who had trauma to the eye, and this would be a very difficult cornea to fit with just an intra or a small lens. And then on the right, this is a patient with Terrian's marginal degeneration, and we know that these patients get neovascularization and scarring and dryness. So these are just some of the issues where scleral lenses are obviously more advantageous than smaller diameter lenses. So let's break it down a little bit now. We're going to look at three components. We're going to look at the irregular corneas, we're going to look at regular corneas, as we talked about with regular refractive errors, and we're going to look at ocular disease. We're going to start by just talking about the irregular corneas, because if you're like me, this is probably the largest group of patients that you reach for your sclerals. So when we think about corneal ectasia, we think about keratoconus, pellucid marginal degeneration, and keratoglobus. When we talk about post-surgery, we're talking about surgeries such as penetrating keratoplasties or lamellar grafts, and then refractive surgery. And in this subcategory of refractive surgery, you not only can have a poor outcome and have just a cornea that has been, well, altered due to the surgery, but keep in mind that you can also have post-surgical ectasia after LASIK or PRK or even RK. So you can have a double whammy with some of those refractive surgeries, and they're very irregular corneas. And then the third category, which I think most of us agree sclerals are excellent for, would be scarring, degenerations, and dystrophies. And what's interesting is if you think about scarring, you think, well, gee, why would a scleral lens be better than a small lens? You still have the scar. But think about what that fibrosis does to the cornea. It actually changes its corneal shape. It's not that they're diminishing the effect of the scar. They're diminishing the effect that the scar has on the surface of the cornea. So let's go a little bit now into looking at some of these ectasias. This is just a few representations. You can see on the left a nipple cone. On the right, you can see how steep that cornea is, where you have the bulge and the thinness of the cornea. Keep in mind that keratoconus is a bilateral, typically asymmetric thinning of the cornea. It's without inflammation. On the right there, that's a pellucid degeneration. If we look at the one on the lower left, all of us will recognize that as Munson's sign. That's when the patient looks down and that lower lid develops a little U shape due to the protrusion of the cornea. And in the lower right, you can actually see a little break in Descemet's membrane or a little scarring. You can get corneas that are so thin that you will get a mini hydrops or just scarring. So we're all familiar with many of those. But what's the most important thing about ectasias and thinning corneas? It's to get that lens off the center, right? So talking now about the post-surgical corneal irregularities, we talked about radial keratotomy, LASIK, and penetrating keratoplasty. And for me, this is the most challenging group of patients because you have shapes, you know, it come from everywhere. So you not only have to think about the underlying condition, but you have to think about the shape. And that's where the material characteristics are going to come into play as well. Think about corneal condition. We're not fitting an inanimate object. We're fitting a living, breathing part of a human tissue. So we're going to start to talk about some of the requirements that these different diseases or entities confer on the patient in choosing our materials in just a few minutes. So I'm really loving this category right now for a number of reasons. You know, look, soft lenses have come a long way. We have wonderful ways of making them customized, of getting progressives, of getting progressive toric, multifocals, and that's all great, but there are still, as we know, some patients who are just ultra sensitive or are dry or we can't get the lens to be stable. Why not go to a scleral? We can pick any diameter, any material we want, you know, in terms of either, let's say, a Boston XO or Boston XO2. We're going to look at some of the things that would decide on a normal cornea, well, what material would you choose? And we're going to talk about that in a few minutes. But these lenses work so well for your active patients. I'm loving them for my younger patients who are involved in sports. Things don't get under them. My older presbyopes who are very dry. So think about the combination of events and the combination of characteristics that these lenses give us. So let's go on now and talk about this category. And I think of the three categories I talked about, ectasias, normal refractive errors, and ocular disease, this probably comes in second. Depending on what kind of practice you have, are you in a tertiary care facility? Do you get referrals from corneal specialists? I do, and I unfortunately see a lot of these patients, but fortunately I'm able to help so many of them. And this is just a list of the numbers of things that we can see. And my hopes is that you guys will never see graft versus host disease or neurotrophic corneal disease, but they're out there. And scleral lenses are definitely a great option, giving that cornea the bath that it needs. So we can now, let's talk about, delve into the material now. And you're going to hear the word balance coming out of my mouth a lot tonight, because that's what we're looking at when we choose material for our patients. And so we call this material science for those of you scientists out there. And we look at 4 or 5 properties, sometimes 6, but these are the main ones. There's oxygen permeability and transmissibility. So oxygen permeability is a characteristic of the material itself. Transmissibility is the term we use when we talk about the material in a given form. In other words, in a given thickness. That's why we have dk and dk over t. So dk is a property of the material. dk over t is a property of the material divided by the thickness of the lens. That gives us a value of how much oxygen is getting to the cornea. The second thing we want to talk about is surface wettability. We all know that gas permeable lenses, as well as soft lenses, of course, and sclerals in particular, have to wet in order for the patient to be comfortable. And the wettability factor will differ depending upon what the patient's underlying problem is. Are they an ocular surface disease patient? Are they a normal patient? How do they handle their lenses? And we're going to talk about ways to overcome problems with wettability in a few minutes. But what about flexural resistance? So if some of you think back to what you learned about soft lenses, we talk about modulus. Well, it's the same thing with gas permeable lenses. Flexural resistance is just that. It's the resistance to flexure. And flexure occurs more readily with smaller gas permeable lenses, but it can occur with sclerals, and we're going to go into that in a few minutes. Hardness, I like to think of hardness as like when you go into the mattress store and you give a poke. Well, how soft is that material? Does it have that pillow top feel, or does it have a little more firmness? And materials will differ in their hardness, and hardness comes into play depending on how rough the patient is with their lens. Are they in an environment that's very gritty? Is their skin very rough? So we keep that in mind in terms of the durability aspect of our contact lenses. So this is a great overview of the 2 materials we're going to be discussing tonight. which are the Boston XO and the Boston XO2. They really are both excellent, but we being the scientists and the clinicians that we are, we delve a little deeper into our decision making. And these are some of the material properties that are going to guide us. We're going to look at decay. Refractive index probably doesn't come much into play, but just know that the XO2 does have a little higher refractive index, so if you do have a high prescription, it may help a little bit to reduce the power that you need. Specific gravity, probably not a big deal. Both lenses have excellent wetting angles. They are a little bit different. Remember that the lower the wetting angle, the more wettable the material. The XO is a little harder. It's a little less subject to problems with penetration if a patient's around a really gritty environment or working where there's construction and there are small, nano projectiles in the air. The modulus for the Boston XO is a little bit greater than the XO2, so it will flex a little bit less. And both lenses, again, offer excellent options in manufacturing. So there you have the summary of the two different materials. And now we're going to go into the pre-fitting evaluation. So what are we actually looking for when we're going to decide upon the material that we're going to ultimately order our lens in? Remember, when you're doing your fitting, you're doing it either diagnostically or digitally. But you're going to get all of your parameters set. But your last thing that you're going to indicate on your order is what? It's going to be the material. And what you see here, this pre-fitting evaluation, is going to really drive your decision, as well as what you're going to choose in terms of diameter and base curve and all of that other stuff. So what do I have here? I have a list of all the things I typically do on, most of them on a general anterior segment exam. But of course, somebody coming in for any kind of contact lens is going to get a topography. We're always looking at corneal clarity. I do my basic dry eye evaluation, which is evaluating lid margin, tear film, conjunctiva. Always flip the lids. Look at that palpebral conjunctiva. Now, when it comes to sclerals in particular, I'm looking at scleral anatomy. Some of you may have a profiler, some not. It's not critical. But what are you looking for? Pinguecula, pterygia, any kind of, certainly if there's a bleb. So you want to look for any lumps and bumps on the conj where that scleral lens is going to ride. And then I love to have my surgeon, if I'm getting a post-PKP patient referred to me, I love to have an endothelial cell count if you'll send it to me. I always do pachymetry and IOP, and we're going to talk about why that's important in just a minute. And now we're going to talk about that. So when we talk about oxygen, so remember we talked about the 4 components of the material science. There was oxygen, hardness, flexure, and wettability. Well, oxygen for me comes first, because if you don't have a cornea that's breathing well, it doesn't matter if that lens lasts a year or 2 years. It doesn't matter if that lens scratches, and it doesn't matter if that lens films. We need to keep the cornea healthy. So we want to look at pre-fitting corneal health, which is why I do pachymetry and endothelial cell count, because you can pick up mild degrees of hypoxia by doing that. And there are ways that we can optimize oxygen to the cornea. And so that's where we then have the beauty of having, a hyper DK lens and a high DK lens. Keep in mind, though, we can go to the next slide. Keep in mind, though, that there are a number of studies, which I'm going to kind of allude to now in a very summary format. And they suggest to us that if we limit the lens thickness and we use higher DK lenses, and we limit the tear reservoir depth and limbal clearance, we will promote more oxygen. The good news, however, is that most of the studies show that the normal, or what's available now, in terms of lenses with a DK of 100 or greater, in the thickness that the manufacturers are producing, which is roughly, 250 to 350 microns, even 400 microns of thickness. I'm sorry, not thickness, but microns of vault, you will still achieve enough oxygenation that is the same as what patients get with an open eye condition, which is less than 4% reduction in oxygen. It's closer to 2%. So what I'm saying is that you'd have to do it'd have to be really, things would have to be really off to not give these patients enough oxygen. It's not hard to deliver oxygen with today's advanced materials, just keeping in mind to work with the thinnest, lowest lens that you can prescribe. You also want to avoid suction. Suction might cause some epithelial edema. That's the force that it takes to remove the lens. So you want to be careful about not having too much suction or too much pressure over the limbus, because remember, that's where your stem cells are produced, and you want to keep that healthy. You want to avoid corneal neovascularization. So avoid suction, monitor your IOP. I do it not just in my glaucoma patients, but anytime I'm suspicious that there might be any kind of corneal edema, which you're going to get by using your, your slit lamp and, looking at it the way you normally would. And then a last resort is just to have the patients, limit their wearing time. And I do have to do this in certain patients, and I have a case that I'm going to share with you in just a few minutes where that added to the success of the case. So we can look at this now, and I think this is a nightmare, not just for the patient, but for us. I'm sure if you're like me, you look at this and you say, okay, what do I do now? Because lenses that don't wet are not just annoying to the patient, but they're annoying to us. So we really want to be sure that we look at the tear film quality and quantity, looking at how that patient blinks. Are they an incomplete blinker? Do they stare? And looking at the meibomian gland health. You need to optimize the substrate, and the substrate is your patient. The product is the lens, the substrate is the patient. So make sure your patient's ocular surface and tear characteristics, tear film is very healthy before you fit the lens. And you're going to run into trouble, from time to time, even with the best looking eyeball not wetting. And we're going to talk about what to do about that in just a few minutes. So we're going to just do the last two properties here material-wise, and that's flexure and durability. When does a lens flex? A lens flexes when we have a rotationally symmetrical lens on a toric sclera. So the way to avoid flexure is to make sure your haptic is well aligned. How do you know that there's flexure? You'll know because you have astigmatism coming through the lens. And how do you know it's due to flexure? You're going to either do a keratometry or topography over the top of the lens. There are other reasons for flexure, which I can go into at the end, but you want to make sure that lens is really centered and that your haptic is well aligned. If flexure is still a problem, then and everything else is equal, then we would choose a material, let's say like the Boston XO2, and then the last resort would be to order a lens that's a little bit thicker. And you can actually order lenses up to 350 microns or 400 microns thick and still be okay oxygen-wise. Now, durability, if you remember, we talked about hardness and the poking and how easily the lens is scratched. And again, durability for me is a last consideration. Look, these lenses are not inexpensive, and I care about my patients' financial well-being, but I care about their health and their vision first. And if they have to place the lenses a little bit more frequently, that's not a problem. But if everything else is equal, yes, I would choose the Boston XO because it does have a higher hardness rating. So now you have an idea of the thought processes that go into making these decisions. So let's just quickly go over lens care. We know that we can order lenses that have something called tangible hydropeg on them to promote the wettability. And I was alluding before to that patient where, you've done everything you could and it's still not wetting, so you might order it with hydropeg. So for that, I would use the Boston Sim Plus. For patients who don't have hydropeg or who may need a little bit more rigorous cleaning, we have the Boston Advanced solution, the conditioning and the cleaner. And then for filling the solution, the scleral fill is great because it's an unpreserved, buffered solution, and the patients can even buy it on Amazon. So those are these are the care products that I use with my Boston lenses. So now we're going to go into a few case studies. I tried to pick cases that I thought would kind of be fun and would sort of illustrate my rationale. These are 3 patients where I had to balance the clinical needs with my choice of lens materials. So let's go to case 1, and I call her the happy high hyperope. This is going to highlight a patient who had actually greater than 10 diopters of phakic hyperopia, and I chose the Boston XO2 material. Let's go into her background. She's a 60-year-old woman. She was actually, I got her more recently. These first few years, my partner was attempting to manage her case. It was actually before we even got into sclerals for the most part, and he was doing all the things I would have done initially. Hindsight, as you know, is 20/20, so I came in at the end and I was able to be the hero. But she was referred in 2013 by a retinal specialist who was following her for retinoschisis. She has microcorneas, which is why she has this high hyperopia. She came to us wearing quarterly replacement methylsilicon hydrogels. And her problem was that she just wasn't happy. Her vision was, in and out. She complained that the lenses were shifting, causing blur. Interestingly, I did have the opportunity to see these lenses on her, and the lenses weren't moving or rotating as much as she thought they were. I think it was a combination of the fact that she had large pupils with small corneas. She's a very unique ocular specimen, but she was not happy. So what my partner did was he went to a custom soft lens, and we can go go to the next slide now. And when we did our evaluation on her, she actually, because she was such a high hyperope and she was wearing methylsilicon, I don't think any of you would be surprised that she had 360 degrees of corneal neovascularization, and lo and behold, this is what her palpebral conge looked like. So those lenses were probably, she felt them moving, and the vision was probably crummy because they were flying all over the place. Her HVIDs were small, as you can see, way less than our typical 11.7, 11.8, and her pupils were big, especially for a 60-year-old. Cornea is very steep, not a surprise, and her refraction, she was a spherical equivalent of about plus 1250 in the right eye, plus 13 in the left eye. And her best corrected vision with the just a manifest with spectacles is, was about 2040 and 2050. So this was a very unusual and very difficult case. Here was her topography from way back, and I think, you can see it was regular astigmatism. There was nothing wrong with her. It's just that the corneas was so small, we didn't get the greatest images. But this basically shows you what she looked like. She had a lot of with the rule astigmatism. We can go to the next slide. Let's talk about what happened next. He tried some custom toric replacement hydrogels. He thought, okay, let me get her into a hydroxysilicon and a higher water content, probably what I would have done. We went much smaller, much steeper, but now she's complaining about glare. Okay, so back then, 2 years later, and she's a lovely woman, so she didn't come back like a month later. She would wait a year or two. She was always afraid of complaining. So she came back in 2015, and we said, okay, it's time to get serious. We're going to get you into gas perms. And we fit her with 9/6 diameter GP lenses. They were in a Boston XO material. And she was seeing much better now than, she was seeing out of the Stoff lenses. But she was still not crazy happy. She was complaining about foreign body sensation. She could feel the lenses moving, and they were fitting well. I did see her myself at this point. So she came back a couple of years later. We'll go to the next slide. And this is 2016, and yours truly is now there, and my partner has retired. And the GPC was all resolved just by putting her into gas perm. We did have her on a mast cell stabilizer antihistamine as well. And her neo, thank goodness, had receded and ghosted. So just putting her into the gas permeable lenses helped us get her medically looking much, much better. But I said, hey, it's time to go to sclerals, okay? Now, I was very nervous about this because This was early on. We were fitting sclerals, maybe not that many, but I'd never fit a patient with a plus 13. But I thought, I'm going to do it. I had read all the articles, and I think I can make this work. So I fit her in a small diameter lens appropriate to her HVID. I aimed for minimal vaulting at the end of the day. I wanted to see 100 to 150 microns, and obviously, at this point, picked a Boston XO2 material. I needed that hyper decay material for her. So let's see how she turned out. This is essentially the lenses that I fit her with. You can see how thick they were because in those prescriptions, you know, this is triple the thickness of your average lens, right? Most of us are using lenses that are 350 microns, and she's up to, you know, 900. But I use the 14.8 millimeter lenses, obviously, and take a look at the minimal vault. This is a cross section of the lens on her eye. And I actually took this picture she was in like 2 months ago. And I was able to get this picture for this presentation. And she's doing great. I see her at the end of the day. I check her pressures. She complains of no fogging. I cautioned her as to what it would look like, what edema looks like in terms of fogging around lights. I mean, I planted every possible symptomatic seed because I didn't want it to go unnoticed. So just, you know, just keep in mind, balance of properties, use a hyper decay lens, go for, you know, a low vault. I tried to go as small as I could and monitor your patient carefully. And you too can fit these very challenging cases. She's 20/30 now in each eye, which is huge for her. And she's extremely pleased with the consistency of vision and the comfort. So that was my happy high hypero. So now we're going to talk about patient number 2, and I call this out of the cloud. This is actually a patient who failed in another custom brand in a very large diameter, and I refit him to a Boston XO2 in a smaller diameter. But what was different about him, we can go to the next slide, is that he actually saw the clouds on the fog around the lights. He was actually sent in by a cataract surgeon. He's a 77-year-old male, essentially in excellent health. He had RK way, like 4 decades ago, RK surgery. And he had cataract surgery then in 2018, so just about 3 years ago. And so think about cataract surgery on an RK patient, you know, there are risks. And so lo and behold, he came down with extensive edema and scarring. And she then had to do a penetrating keratoplasty, you know, a month later. And she had somebody in the hospital clinic fit him. And he developed edema and corneal folds. And she was very flattering, and she said, go see Sue Resnick and maybe she can help you. And so he came to me, and what was interesting about him is that his left eye, and she's a very astute corneal surgeon, his left eye, his endothelial cell count with his new graft is upwards of 2,600. His right eye, the eye that had the RK but has not yet had any surgery, is down to 806. So she was smart enough to understand that with an ECC of 2,600, we should be able to find a solution for him. So I looked at him. He had a clear graft. He had, this is him on the right, interrupted sutures. His implant looked great. There was nothing really wrong with him, ocular surface wise. You know, he had some staining, and why would you see staining on a patient like this? But because the graft now is so young, it's actually concave. We know that as he gets older and this graft gets older, it will start to become more prolate. But right now it's very oblate. So he actually has a little gap, I'm presuming, between his tear meniscus and his cornea. So the goal was not just to get him to see, but to protect that cornea as well. And he had a normal breakup time. So let's go to the next slide, which I think is his topography. Yeah. So this is interesting. Can't explain it all. You should be looking at this and saying, okay, Resnick, how can this topography be this guy? Because it doesn't look like he's that oblate, but when we looked at the previous slide, we saw that donut shape. I don't know. I can tell you that I kind of ignored the topography when I fit him, because when I saw how oblate he was, I definitely reached for a reverse geometry oblate design. So sometimes you have to use your tools and decide you're not using your tools. So let's go to the next slide. So my impression and plan is that he had a good endothelial cell count, that I would refit him with a smaller diameter scleral. I definitely here, knowing that he had been through a hypoxic episode or more than one, I refit him with the exo material with minimal thickness and minimal vol. So I did an oblate 16 millimeter scleral lens, and what I did was I ordered the lens 100 microns thinner than the company normally would do. And this particular manufacturer calls it flex -1. He did require a toric haptic. And because it was an oblate lens, I was actually able to obviously drive that, I was careful about how oblate I made it, because I didn't want to drive the plus power up too much. So I tried to come up with a really nice compromise between corneal vault and the power of the lens. And at 6 hours of wear, he had about 170 microns of vault. I am still watching him. He's a new patient. I'm keeping him. I know that if you tell a patient 6 hours, they're going to go to 8 to 10. So I cautioned him to please try to stay at 6. He's really thrilled because his vision is, he's got 20/20 now with this lens. So again, look at the characteristics, look at the history, and just try to balance your material choice with your lens design and with the instructions to the patient. So we're going to go to case number 3. This is even a little more unusual. This lovely woman, she suffers from severe blepharospasm and secondary ocular surface deficiency. And she achieved much needed relief of her symptoms related to ocular surface disease with scleral lenses. And due to the tear film deficiencies, we did some adjunctive therapies with her, and we'll talk about that. She has bilateral blepharoplasm, and it's a progressive neurological disorder, and the patients get involuntary muscle contractions. It's mediated through the facial nerve, number 7, and they get spasms of the eyelid. It begins gradually with increased frequency of eye blinking, often with eye irritation, and it does progress, unfortunately. They have increasing difficulty in keeping the eyes open. They have light sensitivity. These spasms don't occur at night, but they come immediately upon awakening. And as the conditions worsens, the eyelids often remain closed for long periods of time. It can actually create functional blindness. So she was she was kind of a little bit of a mess. But she also had apraxia, which is a motor disorder caused by damage to the posterior parietal cortex, which wasn't necessarily related to her BEV, but it was just something added to it. And so she's on Botox and lorazepam, and she complains of chronic dry eyes. Interestingly, she scores low on a speed questionnaire, only a 4. And she had already been in scleral lenses, so she was in them since 2017, and she was working with a very good local doctor, but she just wasn't getting the comfort she wanted. And so somebody referred her to me. I can't remember who, but that was nice. And she had tried punctal occlusion and drug therapy, non-steroidal steroids, and nothing was helping. So here's what I did with her. I did her ocular surface evaluation, very careful in the way I do all of my dry eye patients. Her osmolarity did not indicate that she had severe keratitis sicca by any stretch, nor did her tear prism. Her inflammatory was mildly positive for MMP9s. Her breakup time was kind of crummy. The good news is that my Bowman glands looked really nice, but when I went and I did a diagnostic expression, I could barely get anything out. I couldn't even quantify it, qualify it, I should say. It was just really hard to press. But she didn't have any significant corneal conjunctival staining. So what am I thinking here? To me, we can go to the next slide. To me, this points more to evaporative dry eye, but she came in wearing her current scleral lenses, and she was in a non-Boston 100 DK material, seeing very well. She wasn't complaining about vision, and she was using peroxide to disinfect and a non-buffered preservative-free saline. And her complaint was that she wasn't comfortable with the lenses and that her lenses get filmy. So what I did was, we can go to the next slide. I decided that I was going to treat her block lens, so I did do a LipiFlow. She had a very erratic blink pattern because of the blepharospasm, so one could understand why those glands weren't getting a quality or consistent milking action. And I decided I could do a better fit for her, because when I saw her in the other lenses, I wasn't thrilled with the way the haptic was fitting. She had a very toric sclera, and I just didn't love the way the lens was laying, and I could see a little edge lift, and I believe that that was not only causing the discomfort, but may have been causing a little bit of problem with wettability. So I refit her to a small diameter lens, because as you know, the larger you go, the more toric that sclera becomes, and I wanted to minimize the toricity that I would have to deal with. I treated her. We had already done a LipiFlow. She was doing hot compresses at home. She was using lipid-based artificial tears. And I used the Boston XO, but I had it treated with tangible HydraBag. I also changed her care system because I felt she needed more cushioning, and I wanted her to have a buffered solution as sclerofill. And she's ecstatic. I mean, she wasn't that terrible to begin with because the blepharospasm was controlled, but now she says, okay, now I know what well-fitted lenses feel like. And those were really her last words to me. So this was very, very gratifying. So just in summary, I hope the takeaway for you was that the XO and XO2 materials give us the ability to fit our patients not only from an anatomical perspective, but also a physiological one, balancing oxygen, wettability, and modulus. And you know, Bausch has been around actually longer than I have, if you can believe that. They've been around since 1853. So I've been working with Boston Materials ever since I was fitting gas permeable lenses, and I just have a trust in them, and I know how they're going to perform. And you know, the best part for me is seeing these patients happy, but the other best part for me are these lab consultants. And I think for those of you doing a lot of fitting or just starting, that is your best resource. So I hope you guys learned a little bit, and we definitely want to, you know, start to, you know, answer some questions for you.
Excellent. Thank you, Dr. Resnick. We're just going to put up the important safety information slides for your viewing pleasure while we wait.
You can read this very fast because I'm from New York. Do you want me
to? And what we would like to do is just give you guys a few minutes to type in any questions, and we'll get back to you in one moment. Okay, I've got a couple of questions right off the bat here on flexure. Pull them up here. So Dr. Resnick, we have a question here of how do you clinically check for lens flexure?
So I, you know, so the first thing that would possess me to, or, you know, compel me to check for lens flexure would be when I'm doing an over-refraction and I find astigmatism. I want to know, is that astigmatism coming from somewhere off the back surface of the cornea, or is it coming from the front surface of the contact lens? So very simple. I do an auto-refract over every lens I put on a patient anyway. That'll give me the auto Ks, and if it looks like there's astigmatism on those auto Ks, I know that there is flexure. And so that's simple. Or you could do a topography over the lenses as well.
Okay. It looks like there's a follow-up there. What else can masquerade as lens flexure, and how do you differentiate?
So sometimes a patient, excuse me, will complain about ghosting or monocular diplopia, and you check for astigmatism, but you don't see it or find it. That often is due to a prismatic effect of the lens not centering well. So what I do, and typically, as you know, lenses tend to decenter inferiorly and temporally due to just the way our eyeballs are constructed. So I take my finger, and I push the lens up to where it's perfectly centered. And if the patient then says, oh, the vision's better, I know that I have to do a better job of designing my haptic to get that lens centered better.
Okay. I've got a couple here on HydroPeg. In regards to the HydroPeg, what is the best way to care for this lens?
So with HydroPeg, you want to use no tap water, which the patient shouldn't be using anyway. You want to use nothing gritty, which is why you want to use the Sim Plus versus the Boston Advanced. So nothing gritty. And you want to have them, you know, just for them to understand that there is a coating on the lens and that they have to handle it with care and not to drop it on the surface and things like that.
Okay, great. And I think you answered that. It was really what products to avoid, those abrasive solutions. And
Yeah.
great. Okay. Okay, I've got another one here. Do you adjust material choice in any way for ocular surface disease for patients, and for which underlying conditions? And I know you talked a lot about ocular surface disease. Maybe just expand on that a little bit if you can.
So yeah, I mean, if you look at the at that graph that we did where it shows wettability, the wetting angle for the Boston XO2 is actually better than Boston XO. But if you're paying attention, you noticed in my case with ocular surface problems, I still kept her in the Boston XO because I felt that there were other properties that took precedence. So you have to look at that. Both are excellently wettable, but I would, don't hesitate to use the tangible. So, if I really feel that I need if all things are equal and I'm using the Boston XO2 anyway, I have the benefit of the lower wetting angle, but I will still use tangible HydroPeg on it.
Great, great. And that there was the next question, also talking about the HydroPeg. If you choose not to, basically asking, how is the wettability of Boston?
I've never had a problem. I mean, look, no, that's not true. You're going to have problem patients. But I've always found there's a way around it. And, it's so easy to blame the contact lens on the material. So you really have to treat the patient's underlying condition. So figure out, is it evaporative dry eye? Is it tear quantity problems? Do they need to be on some sort of pharmaceutical? Do they need punctal occlusion? I find that punctal occlusion works really well in contact lens wearers, better than in my non-lens wearers who have dry eyes. So use all the tools in the belt to get the patient's eye and tear film as healthy as possible, and then optimize your lens materials.
One question here says, you have a lot of repeat patients that purchase scleral lenses again and again with XO and XO2. And how do you find the reproducibility when ordering the same prescription in a year to 18 months after the original? And I know from your cases, you had a few that they do take their time to come back.
Right. It's interesting because I've never actually thought about that before this question that you just threw to me. So I guess I have to tell you, I haven't had a problem because my patients will just order, they'll order without asking me because they know that nothing's changed or I've seen them. I mean, I see all my patients twice a year, by the way, at least twice a year, some 3 times a year. My graft patients, I see 3 times a year. My other patients, I see twice a year. So at each visit, they know that that lens prescription is valid for a year. So sometimes they have multiple homes or they're going away or they're nervous about losing a lens. I've never had them come in and say, look, I have, a lens from 2018 and I just ordered this 2020 and they're supposed to be the same, but they don't. I haven't had a problem, to answer your question.
Mm-hmm. Great. With your patients, do you inspect your scleral lenses on a 6-month or 1-year follow-up visit? And if you do, what types of things are you looking for?
So yes, I see my patients every 6 months. I'm looking at the lenses and I'm looking at their eyes. I'm looking to make sure the lenses are wetting well, that I don't see any cracks or deep scratches that would compromise the vision. And then I'm checking their corneas. I want to make sure I don't see anything different. And I will admit that there are times where I look back and go, oh gosh, was this there before? And as good as I think I am, I'm nowhere near perfect. So you really document everything. If you see a vessel at 2 o'clock, write it down. But basically, I'm just doing my exam and making sure that on the whole, they look as good, or as good after lens wear or better than they did before I fit them.
Okay. Excellent. Are there any other questions that anyone has? We'll give another minute to type in, but I think we've gone through the list of questions that have come in. Well, if not, thank you all so much for attending, and thank you, Dr. Resnick, for an excellent and informative presentation. And we will wish you all a good night.